afternoon, friends. Today we are going to discuss the role of ARNI or in both heart failure with reduced ejection fraction and with preserved ejection fraction. And basically what I'm presenting today is a new pathway, and this has been kind of a national consensus. So this is a 15-point consensus that we'll discuss in the end. Today's presentation's highlight is that I will be presenting this in a question answer format. So most of the times you have a presentation, then you have the audiences asking question. Here I'll present the question, I'll answer that, then present the data supporting that answer, and then we'll move on. So these are some truths, and they are all sad. Why? Because it's a deadlier disease. Many of those cancers that you know already can kill are breast cancer, Hodgkin's lymphoma, NHL, colon and rectum cancer, leukemia. All of these are quite frequent cancers. Many of us physicians will come across these cancers in our patients. And the worst mortalities of leukemia, which is 43%, that of breast cancer is a small 11%, but heart failure supersedes all of these, and the mortality here is almost 48%. Then we know that this is a progressive condition and the mortality is very high, as we have seen in the previous slides. The disease unrelentlessly, it keeps progressing. You have peaks and troughs of patient feeling better, again worsening, feeling better and worsening, but all the time with every subsequent admission or presentation, the patient's general condition keeps going down, eventually leading to mortality. So a very high mortality related disease, which is relentlessly progressive. Not only this, patients who do not even die are at a very high risk of developing frequent hospitalizations. And we know that 9 out of those patients are symptomatic, even with whatever treatment you are offering them. Nearly 1/3 of these patients with HFrEF are at high risk of hospitalization and severe death. And with every presentation, we know that the mean survival, it keeps spiraling down, and actually you will lose the patient. Or geographical different location. Global mean age of the patients is 73 years, while in India it is a much smaller number of 53 years. In hospital mortality globally is recorded to be below 4%, while in India it is to the tune of more than 30%. And the post-discharge mortality of global data shows 8.6%, while in India it is more than a quarter of these patients. So prognostically, we are faring much, much worse by being affected at an early age and by dying inside the hospital and having a very high mortality outside of the hospital also. These rates, or as shown in the inter-CHF study, showed that patients with heart failure would be dead within a year of diagnosis. So if you look at the cancer data of mortality and look at this, cancer would kill over a period of several years, while in heart failure, more than a quarter or nearly a quarter of those Indian patients would be dead in less than a year. Much worse than the cancer or many of those cancers combined together. There are at least 8 to 10 million patients of heart failure. This again could be actually a is known is also huge, which will tantamount to 1% of the adult Indian population. And heart failure in India post-admission has a mortality, as I told you earlier, 50%. Despite all of these, the medication adherence ranges to less than 50% amongst these patients, and we are losing a young population to this particular disease. The 5-year mortality and readmission rates in patients, as shown in this Trivandrum registry, it's also quite alarming. And what is even more important is that only 25% of patients who were discharged from index hospitalization were receiving GDMT or the guideline mandated directed therapy. So what are your goals? You want to increase the survival of your patients. You don't want them to come back and have repeated hospitalizations. And first and foremost possibly is to make the patients feel better. So how have the RCTs progressed in the treatment of heart failure? We know the drugs which are available for heart failure today is ACE inhibitor or ARBs or ARNI as we say today. Mineralocorticoid receptor antagonists would be spironolactone or eplerenone. Are the three pillars of heart failure treatment as of today. Add to this SGLT2 inhibitor. Then, of course, hydrolazine isosorbide, their combination was studied in the African Americans. And digitalis has been available since eons and has been known to improve symptoms, but the mortality data remains uh, uh, not that exacting. So all this started within, say, in the early 80s, mid 80s, and we showed the superiority of beta blockers in ACE inhibitors. So big jump had come much later, and that came with paradigm and later on ivabradine was importantly added to the armamentarium that we have. So the biggest leap amongst all of these came with the paradigm heart failure study, which actually demonstrated the benefit of uh, me over enalapril. Here you had more than 8,500 patients randomized to the experimental drug, which we now call as ARNI, and this was compared to enalapril, which was given in a very standard good dose of 10 milligram twice a day. And these were patients who had an ejection fraction below 35%. All of these were so-called stable patients who were receiving already ACE or ARB and were on other current state-of-the-art therapy. So this is the largest morbidity and mortality trial in heart failure with reduced ejection fraction, very geographically diverse and racially diverse also. So ARNI uh, showed compared to enalapril reduction in cardiovascular deaths by 20%, heart failure hospitalization by 20%, and the overall mortality went down by 16%. Certain deaths were also reduced. So if you look at this comparison, the number needed to treat with an ACE or ARB would be 26 to reduce one mortality event, while with beta blocker it is merely 9 patients. With aldosterone antagonist it was merely 6. And when you look at this against ARNI, when you need at 32%, the mortality reduction was to the tune of 21%. So the relative risk reduction on top of all of these was 20%. So here the number may not look dramatically big, but when you remove ACE and ARB, you'll find those who had received these drugs plus all of these, they still continue to have a big reduction in mortality. Similarly, was a change in class of the patient, and other outcomes were also affected. We showed that ARNI is superior to ACE inhibitor across all various subgroups, be it pertaining to age, ejection fraction, GFR, systolic blood pressure, or NT-proBNP levels. Remember, the answer to this question is do not wait. And we shift as of today. If you have any patient on ACE or ARB whose ejection fraction has not shown improvement at least, or has shown a very sluggish or staggering improvement, each and every of these patients should actually be switched to ARNI, because you think that a patient is stable while they are not. As I told you in paradigm heart failure, 20% of the stable patients actually died or had a primary event during the course of this trial. So what might appear to be stable disease is actually not stable. People keep on dying despite looking very stable. So there is nothing called stable heart failure. The patient is just compensated or they are decompensated. Everybody else is on the death row. So remember, any patient who is showing an illusion of stability is actually uh, luring you into complacency and might actually kill the patient. So you want to reduce heart failure hospitalization, you want to reduce death. Each and every patient of heart failure with ACE and ARB should immediately be switched over and started on ARNI. So do not wait for certain forms of deterioration. And these are your current recommendations. Uh, the current recommendation for class 1A in patients with say 2 or 3 symptoms, use of ARNI is recommended to reduce both morbidity as well as mortality. ACE and ARB only when ARNI cannot be given for certain reason. Those reasons are actually such few and far in between that you will hardly find any patient who cannot be given ARNI but can be given ACE or ARB. Second question is, do you think that a patient who comes with a known heart failure and gets decompensated different from a patient who presents for the first time, that is de novo heart failure? Again, yes, these two classes of patients are dramatically different. So acutely decompensated chronic heart failure, uh, patient looks maybe older, would have a worse baseline status and lab findings, and de novo patients are the ones who do not have a history of heart failure. There are certain comorbidities associated with ADHF patients which may not be seen in de novo heart failure, although not always so. There are certain triggering agents who are chronically compensated patients, while here it may be more ischemia or valvular disease. Presentations in decompensation are more like dyspnea, orthopnea, ascites edema, while here in de novo heart failure, they may most likely present with acute pulmonary edema or shock or a combination of these two. So de novo patients are quite different from the patients who are presenting with acutely decompensated heart failure. So everybody should get discharged on ARNI and do not have to wait for first visit or a follow-up visit. So now your uh, strategy should be that if you have seen a patient of ADHF, you shift them from ASARB to ARNI, and if they were not on any of these and now getting ARNI getting discharged, all of these patients should actually before discharge. If for some reason you cannot do that, maybe creatinine levels are going up, or patient is hyperkalemic or hypotensive, in those cases, take an early follow-up visit and try to start at that time. So this will not only reduce the symptomatology, but it will reduce death, hospitalization, and you can see that anti-proBNP levels also going down. In subgroup analysis of patients with de novo heart failure, uh, change in NT-proBNP, history, heart failure hospitalizations, and everything else seem to be faring much better with ARNI as compared to enalapril. So when you see such early clinical outcomes improvement, there's no point in waiting for the patient to come back and then start. So here, early clinical outcome was not supposed to be seen, but then it was actually quite clinically evident that patients, even those patients who had no prior exposure to ACE or ARB, there again you had a clinically significant change in NT-proBNP, and again the event of death or hospitalizations were significantly altered. Yes, again, the answer to this question is yes. In all de novo patients, it's a challenge to look at their hemodynamics, but once they are monitored, while you should know that most of these patients and could be started on ARNI pre-discharge. In fact, many of these can be given this medicine during hospitalization, and of course on discharge ticket you should have this molecule, because the de novo patients also are likely to live longer and free of re-hospitalization when ARNI is started pre-discharge. So, initiation of sacubitril was studied again in patients with newly diagnosed or de novo heart failure, and this is a subgroup of transition study which showed that echocardiographic parameters in hospitalized HFrEF were improved significantly. There was a reversal of remodeling in these patients, and both of these was significantly better as compared to ACE or ARB. This you can see biologically or biochemically on a reduction in T levels in these patients. So not only that, more de novo patients would achieve a target dose at week 10, and fewer had serious side effects or permanent treatment discontinuations, again as compared to ACE or ARB. So it's easy, it's better to start a ARNI pre-discharge in these patients. It's better in terms of results as compared to ACE and ARB, and it is also better in terms of tolerance. So always consider ARNI to be the first line again in these patients who are presenting with de novo heart failure to prevent further progression and sudden deaths. So the 2021 update in consensus pathways again shows down of being first drug advantage now sits over the head of ARNI and not on ACE or ARB. Then of course there are certain of these molecules start. Here again, I would like to focus on this particular part of the slide, which shows that black patients, despite ARNI or beta blocker, will receive a hydroxyzine isosorbate dinitrate. Why I'm focusing on this is that I see very frequently patients receiving nitrate hydroxyzine combination in India for heart failure when ARNI has not even been tried or tested in them. Remember, the drug of choice in everybody except black is ARNI. Even in blacks, ARNI has done better, although ACE and ARB are not seen to be working in this particular racial group. Here is that molecule which has shown that mortality can be reduced. In Indian race specifically, I wouldn't say that we have any robust data for nitrate and hydrogen combination. So always stick to ARNI or ACE or ARB. So a given period of 3 to 6 months should be the maximum wherein you can achieve the standard and target doses. So always consider ARNI to be the first line therapy, and always give them precedence over ACE and ARB. Remember, when you are switching from ASRB to ARNI, you have to provide a 36 hours wash off period before you can actually start. That would be the standard thing. So if your patient is 10 milligram or less dose of enalapril, the valsartan dose is equivalent of 160 milligram or less. Since uh, sacubitril comes in a fixed dose that you cannot specifically choose. So remember, valsartan 160 and enalapril 10 are equivalent. And similarly, if they are taking more than 10, then you can go from 160 to 320. Remember that you need to monitor the blood pressure, renal function, and potassium, and accordingly, you can up titrate the dose. So again, the answer is no. If you do not achieve the target dose, the benefits are not going to be accrued upon the patient. They will still have advantage, but the advantage would be much lesser than what they could have actually achieved. So why people would not tolerate sacubitril valsartan? Some people would observe a worsening of GFR. There may be hypotension, very common, hyperkalemia, GI symptoms unusual, but yes, they can. But many of these are actually not the reasons why you should not be able to achieve the doses. You can actually still do that. So the benefits, irrespective of the dose, the 100% of target dose is still beneficial. 50 to 100% target dose is still beneficial, but at 50% or less, you'll find that the benefit starts actually wearing off. So overall, ARNI in some dose is still better than not giving ARNI at all, but that should not defer you from trying to achieve the targets. Try to go higher as much as possible. So they still would have a lower dose, would still have a lower risk as compared to other people or compared to enalapril, but a higher dose and a lower dose patient, the patient who is receiving a higher dose is likely to fare much better. I would say the answer should be actually yes. So here we are not trying to treat the hypertension as such, but a patient who has hypertension also in a patient with HFrEF. So compare these to any other molecule, you'll find that a patient with borderline or a small degree of hypertension and HFrEF, sacubitril valsartan or ARNI favors, finds favors as compared over enalapril. Again, these patients who receive ARNI for this kind of hypertension are less likely to be hospitalized or have subsequent heart failure. Now, hypertension should not be one thing which should be actually frightening you, because you will find that enalapril patients are more likely to have hypertension as compared to sacubitril valsartan, despite its seemingly high dose. This is the beauty of remodeling, because as heart remodels, the cardiac output improves and you will still continue to have good blood pressure. So there are certain rules here. The most important thing is correct volume or salt depletion, because you are going to give these patients diuretics. You have to tell them that they have to restrict their fluid and salt intake. So if you find them dehydrated, hydration level should be corrected, salt has to be corrected. If that is not so, but the patient is on a high dose of diuretic and developing low blood pressure that is systolic below 100, In those cases, start with this reducing the dose of diuretics first, and then think of changing the other drugs. Now, it is always better to start with a lower dose. So, lower starting dose with a slower up titration is the key to keep a reasonable amount of blood pressure without actually leading to patients hypotension and acute kidney injury or hyperkalemia. So start low, go slow, but try to achieve your target gradually but slowly, which should be done consistently. So a hypotension in most of these patients can be managed without altering the dose of ARNI, but if needed be, you can always go down, wait for the BP to improve, and again try to apply. This surprisingly to this we have very little data, but what we have in the form of data is that if you started in on an ARNI on those patients who are actually slated for a CRT because of non-response, you will find that over a period of time, the ejection fraction, troponin I, NT levels, NT-proBNP levels, they start falling down. In many of those patients who were slated to receive a CRT or an ICD or a combo, they are started on ARNI, they actually do not remain a candidate that much because of the remodeling and the ectopics going down. So ARNI should be considered before actually embarking upon device implantations. So many of these patients who are on ARNI, they have known to be now seen to glycemic control, reduction in the onset of insulin in these patients, or a reduction in the dose of OHA. These are pleiotropic benefits. They are not randomized trials. They are sub-studies and sub-analysis of the already existing studies. This might need confirmation in a randomized trial, which may not be done at all. But remember, so far as glycemic control is considered, ARNI will have a favorable impact on it, at least not a negative impact. So when glycemic control will improve, chances of new use of insulin is less, and more chances of not starting an OH in these patients if they were all. By very strict definition may not be called as having preserved ejection fraction. Maybe they would be called as minimally reduced ejection fraction patient. So completely unequivocal answer cannot be given to this. But remember that using ARNI in HFpEF patients, especially those borderline where you're not sure whether they have gross degree of LV dysfunction, they might still benefit from ARNI instead of ACE or ARB. Although a clear-cut answer as can be given in HFrEF cannot be provided as of now for uh, the ejection fraction definition in different trials has been different. Now, somebody has say preserved ejection fraction, which may actually, by definition, should be more than 50, but there have been patients in HFrEF trials where the HFpEF trials where the ejection fraction actually was between 40 and 55. So these patients are very likely to benefit because maybe they are somewhere between HFpEF and HFrEF. So this middle path patients are definitely the ones who are likely to benefit less as compared to HFrEF patients, but nevertheless, compared to ACE and ARB, they will do better. There would hardly be any, as I told you that. And if still, suppose you are giving somebody ARNI and they keep on developing hyperkalemia, remember there are several other things which need to be done rather than affecting the dose. So look at potassium intake of the patient. Many of these are taking nariyal panis and fruit juices, several other forms of Ayurvedic kadhas where potassium might actually go up. Loop diuretics, especially if you are over treating them, over dehydrating them, that can cause hyperkalemia, and the potassium sparing diuretics. All of these things should be considered for treatment of hyperkalemia before actually started starting to treat or reduce the dose of ARNI. But of course, when they come with hyperkalemia, go along standard lines and treat hyperkalemia first. The answer again is yes. ARNI withdrawal in patients with heart failure and reduced EF would have an increased all-cause mortality. So it is not merely a withdrawal of this drug would lead to reversal of problems. It might actually lead to a jump side also. Similarly, if your patient has already improved ejection fraction, starting low, getting better over a period of time, the reduced towards improved ejection fraction, what do you think of discontinuation? Again, the previous slide was important. You should not discontinue the drug. Most of the times it is better to reduce or stop diuretic. You can stop digitalis. You can even stop mineralocorticoid receptor antagonist. But even these patients who have improved ejection fraction now should be continued on ARNI and beta blocker as well. So this would conclude most of our talk. So from this consensus, learn that ARNI is the molecule of the century. It is indispensable and superior to ACE inhibitors in reducing deaths, both CV death, heart failure death, hospitalization for heart failure, as well as sudden cardiac deaths in HFrEF patients. It improves EF, reverses LV remodeling, and improves quality of life. And it should be initiated as early as possible and stuck to that and take them to the standard doses. And you would be adding several years to patients' lives. It should be given for at least 3 to 6 months with other foundational therapies and reassessed with even MRI before the patient is considered for ICD. So any device therapy which is likely to benefit should be challenged first by giving the ARNI to patients in proper doses and see whether they will eventually require those or not. And all patients have PEF and EF less along with SGLT2 inhibitor. You would use ARNI to reduce hospitalization and improving quality of life. Thank you so much. If there are any further questions or queries, I'd be glad